Hello, everyone, and welcome. My name is Kaylee Dayton. I'm a critical care consultant with Dayton ICU Consulting. I'm a nurse practitioner on a mission to create awake and walking ICUs. And today I'm really excited to talk about an important topic that definitely guides and impacts how we approach managing patients on mechanical ventilation in the ICU, and not always for the better. We're going to talk about unplanned extubations in correlation with the ABCDEF bundle. And this is a hot topic throughout our ICUs all the time. And so today we're going to talk about not only how we can limit the rate of unplanned extubations, but how we can protect patients from the negative repercussions of unplanned extubations. And this safety net is called the ABCDEF bundle. And that is a protocol that guides how we care for patients in the ICU, and especially on mechanical ventilation. And when we truly master the ABCDEF bundle, that is how awake and walking ICUs are born. Like this patient here on a PEEP of 12 and 70% cruising through the halls. So I started my career in this ICU. When I was a brand new nurse, I was interviewing into this high acuity medical surgical ICU in Salt Lake City, Utah. And the nurse manager asked me point blank, would you be willing to walk patients on mechanical ventilation? And I had no idea what that meant. But I enthusiastically nodded my head and said, yes, of course, because I was new and very malleable and excited to learn. And working in that ICU for a few years, I didn't realize how important or how novel that practice was, because to them in that ICU for almost 30 years, the culture and the practice has been to allow almost every patient to wake up right after intubation and mobilize shortly after, unless there was a certain indication that required sedation, especially to be comatose, or a contraindication to mobility. Otherwise, patients were up and cruising around. And so you may be thinking, this doesn't sound like a real ICU, or these are long-term venters, or this isn't high acuity. For context, there's a bone marrow transplant unit in the hospital. There's a detox unit down the hall. It's next to a drug park, a shelter. It gets ARDS transfers from all over the region. And during COVID, it had one of the highest acuity COVID ICUs in the state of Utah. And yet they continued this practice of allowing almost all patients to be awake and mobile on the ventilator, unless, especially during COVID, they couldn't oxygenate with movement or there was a need to be sedated. So this is what the ABCDEF bundle really looks like. And that team went almost over 2 years without any unplanned extubations. And let's talk about why. The ABCDEF bundle is a combination of different tools to use to optimize and customize patient care. And I love what my good colleague Heidi Engel calls it. She says, instead of the ABCDEF bundle, what if we flip it and make it the F2A bundle? So F is for family. If we make family a top priority and an equal member of the ICU team, then we will want to have our patients be awake, engaged, connected with their families, communicative. And when we do that, then they are awake. They are ready to be mobilized, and we will do prompt mobility, as soon as possible, and usually shortly after intubation. And we will do the highest level of mobility unless there's a contraindication. And when we have F and E in place, then D, which is delirium prevention, assessment, and treatment, naturally falls into place, because some of the most potent tools to treat delirium and prevent delirium is family and early mobility. And so when we put it in this order, D falls into place, we can prevent, assess, and treat delirium. And we will always utilize C, the choice of sedation and analgesia, customized for each patient. This should not only trigger us to avoid benzodiazepines, but to ask after each intubation, does this patient have an indication for sedation? And if there is an indication for sedation, such as intracranial hypertension, seizures, the inability to oxygenate with movement, then we will choose the safest sedative at the lowest dose for the shortest duration possible. And we will continue to ask after each intubation, each shift, every day, every round, does this patient have an indication for sedation? And once there is no longer an indication for sedation, once the intracranial pressures are in a reasonable range and such, then it's time to do an awakening trial. to see if we can keep patients off of sedation for the goal of sedation cessation. And when we do those awakening trials, we will involve these other tools of having family there, being ready to mobilize our patients, assessing for delirium, and be ready to treat it rather than automatically restarting sedation to mask the delirium, the agitation that we've witnessed. And when we do that, then we're often ready to do breathing trials, and we will continue to assess and prevent pain throughout this process, and almost even better so when patients can tell us what they're experiencing and what they need. And this is how they can often look during mechanical ventilation. This is a COVID patient in that Awake and Walking COVID ICU. Playing the guitar, this is, I think, over a week after intubation, he's still awake, oriented, alert, and strong enough to strum a guitar. And it's because they've mastered this A to F, or rather F to A bundle. So when we see this as a toolbox, not just a go in orders A, B, C, D, E, F, but we see these are just acronyms to remind us of all the tools in our box, we then can know how to really customize and optimize care for our patients. And a lot of times teams will tell me when we're talking about sedation mobility practices, oh yeah, we practice the ABCDEF bundle. But what they really mean, or what is actually happening, is that they have mandated CAM, RAS, awakening trials, and breathing trials in their charting systems. That they have a few of the elements that are often, not fully done or incorporated into the culture, but yet they have certain checklists. And that's what we have understood throughout the ICU community to be the ABCDF bundle. What's really tragic is that when we have that approach of just mandating certain tasks in our charting system without truly changing the culture, we miss the overall objective and mission of the ADEF bundle. The true purpose is not just to document CAMRAS, SAT, SBT, but it is to produce patients that are more awake, cognitively engaged, physically active, to facilitate patient autonomy and the ability to express unmet emotional, physical, and spiritual needs. So the APCDF bundle can look like this for most patients. This is a cute, wonderful woman that we cared for that had interstitial lung disease. She had aspiration pneumonia and was obviously intubated on mechanical ventilation. She was allowed to wake up right after intubation. She hung out around a PEEP of 10, 12, 6, 70, 80% for a while. Yet she got to choose what Harry Potter book she wanted to listen to, what movie she wanted to watch. And she even got to choose when it was time to remove mechanical ventilation, as she was at end-stage interstitial lung disease. She made that choice. She told us she wanted to take a sip of Diet Dr. Pepper, a Slurpee from 7-Eleven before she passed. She decided who she wanted to be there. She got to say her goodbyes. This is what the ABCDF bundle can look like for many to most of our patients in the ICU. But for anyone that's worked in the ICU, especially throughout many ICUs, we know that there is a spectrum of compliance with the ABCDF bundle. Sedation and mobility practices fluctuate drastically between ICUs, but even between clinicians within the same ICU. So we can have a low compliance with the ABCDF bundle, which is when we automatically deeply sedate every patient without even asking whether or not sedation is necessary. But there may be some awakening and breathing trials. Usually in this kind of low compliance, awakening trials only happen to the extent of turning down sedation enough to see a patient thrash, turning it right back on. And then we can have a little bit better compliance when we have daily awakening and breathing trials, where maybe they're happening every day, but still with deep sedation, quick to turn the sedation back on. Then a little bit better compliance is with some light sedation with daily awakening and breathing trials. Better compliance is no sedation if there's not an indication for sedation, but maybe not a lot of mobility going on. And then there's the other extreme of an awake and walking ICU, in which every patient is allowed to wake up after intubation unless there's an indication for sedation, and they are able to do the highest level mobility promptly unless there's a contraindication to mobility, and there are no visitation restrictions. Families are a full integrated part of the ICU at any hour. That is an awake and walking ICU, and this is what it looks like for most patients. And I know that when people see this, one, it can be shocking. For clinicians throughout most ICUs that have deeply sedated most patients on the ventilator, this can be a surprising and shocking presentation. And then without fail, the question I always get is, That's not safe. What if they self-extubate? So let's dive into that. Unplanned extubations are a huge and legitimate fear in the ICU when we have patients whose lives rely on being connected to mechanical ventilation. So, what are unplanned extubations? They're tube removals that were not anticipated when we do not know if patients are in safe parameters to be off of mechanical ventilation. 63% of unplanned extubations are self-extubations. 37% are accidental extubations, which is usually during transport, going from the bed to the stretcher, turning, bed baths, things like that. Those are unplanned accidental extubations that were not done by the patient, but usually by the clinicians. And there are some inherent risks that come with unplanned extubations. That's why we're so concerned about them. There's risk for laryngeal cord, vocal cord injury, hypoxemia, respiratory failure, tachyarrhythmia, hypotension, aspiration, pneumonia, and even death. So 0.5% to 35.8% of unplanned extubations result in reintubations. So the risks and even the reintubation rates seem to really vary between ICUs, and likely they vary just as much as our sedation mobility practices. And we're going to dive into how those are so closely intertwined. So when we're looking at how much should we be concerned about unplanned extubations, what is risky about them, is mobility really one of the top risks for unplanned extubations? Absolutely not. When we look at tens of thousands of mobility sessions that have been redocumented throughout the studies, we find that a less than 1% adverse event rate. And those adverse event rates include a lot of things, not just unplanned extubations, but also cardiac arrhythmias, hypoxemia, falls. So all of those events put together, there's still about a 0.6% adverse event rate. There's one study from 2007, looked at a couple hundred patients, intubated patients during mobility sessions, and found that there were none events for unplanned extubations. And that's been my experience. I personally have seen likely thousands of patients mobilized in mechanical ventilation, and I've never seen an unplanned extubation happen during mobility. Yet when it comes to bed baths, unplanned extubation is one of the most common adverse events that happen during nursing care. So really, which is more dangerous, which has the greatest risk, which should we be most concerned about? And it is not mobility. So what are the risk factors for unplanned extubations? According to the studies, which were done long ago and probably in a different culture, these were identified: inadequate breathing tube stabilization, patient restlessness and agitation, inadequate sedation, use of physical restraints, absence of clear policies and procedures related to weaning, factors related to nursing staff, so inexperience, night shift, inadequate staffing, and the use of midazolam to decrease agitation. So when I looked at these risk factors, I really tried to hold them up against my experience, right? And in an awake and walking ICU that has hardly any unplanned extubations, when did I see those happen? And yes, when they occurred, patients were restrained, and yet they still happened. But let's dig deeper. Why were they restrained? Because they were delirious. I mean, obviously, awake and walking ICU has far lower rates of delirium, but it still happens. And that's when it seems to happen, is when patients are delirious. But why isn't that identified in the literature? Well, if we look back to the dates of these studies, 2012, 2011, 2005, these are old studies, and we look at the history of delirium, especially delirium screening in the ICU. CAM screening tools did not become standardized until about the 2016. And so these studies were happening before we were really aware of and screening adequately for delirium. But I see clear signs that delirium is a huge risk factor. We see one of the identified risks was restlessness and agitation. Anyone that's worked in the ICU knows that is a top sign of delirium. The use of physical restraints, those restraints increase as our delirium rates increase. And the use of midazolam to decrease agitation, as one study showed. And so, which is terribly ironic. Oftentimes, again, one of the main causes of agitation in the ICU is delirium, and yet midazolam is a benzodiazepine, which carries high risks of delirium, which we'll get into. So I see clear signs here of delirium. agitation, restraint use, benzodiazepines, even in those older studies. But one study from 2018 did look for the correlation between delirium and unplanned extubations. When they looked at a sample group of 50, which had very few unplanned extubations, they didn't see any correlation. But when they increased the sample size to 100, boom, they found it. Another retrospective chart review from 2017 looked at delirium and unplanned extubations and found that delirium increased the risk of unplanned extubations by 11.6 times, and agitation increased those risks by 9 times. So it can be very clear that we set up a scenario, the perfect climate for unplanned extubations, when we create what Wes Ely calls a delirium factory within our ICUs. And to make that come to life, we have to understand the risks of delirium. We have to see it as acute brain failure, that it is a medical emergency. There is a dangerous disruption happening in the brain, and this can be caused by lots of different things and many unmodifiable risk factors that patients come to the ICU with. Drugs, whether it's drug toxicity, drug withdrawal, drugs that we are giving in the ICU, such as sedation, which we'll get into, ears, eyes, and other sensitivities, low oxygen saturations, infection, retention of urine or stool, post-ictal state, underhydration, undernourishment, metabolic causes, subdural hematomas. So a lot of these things are unmodifiable. Patients show up this way, but there are also things that we're doing to patients to cause it. And one of those is sedation. And I want to clarify that we give sedation more often than not with the most benevolent and humane of intentions. We have culturally inherited this belief that sedation is sleep, that patients are as calm and comfortable as they appear as they lie there motionless and with their eyes closed. But if you look at the research and you hear it from survivors, they will tell you a completely different story.
Sedation is not sleep.
Sleep deprivation.
Delirium is not just confusion. It's definitely not pleasantly confused.
Perceived reality that doesn't go away like a dream.
Sedation means deep trauma,
psychological terror.
It's not knowing your wife and assuming she's an imposter seeking to do harm to you to help with medical staff. Perceived sexual abuse for what are normal medical procedures. Perceived reality that can only be described as hell.
The damage of delirium stays with us long after we leave our ICU. Depression, anxiety, cognitive impairments.
It changes your relationships, changes how you identify yourself, you identify with your body. Every relationship that you have will all be forever changed.
Loss of life we knew before.
Loss of self-confidence.
Sedation is not funny content for memes.
It did not spare me the trauma.
They had to resume sedation during that awakening trial. And obviously that locked me back into the terror of being sedated.
Let me communicate with my family.
please let me get out of bed. Let your patients get out of bed.
I would prefer any real experience to the unreal experiences that I have. It's like to you, Miriam.
We come out of sedation thrashing because of the rat race of horror sedation is caused.
Before you automatically sedate us, make sure it is absolutely necessary.
This delirium day, let's not just bring awareness.
Let's bring change.
For millions of ICU patients to come.
And I know this is grossly misunderstood. This is not our intention to torture our patients or have them be traumatized during the ICU. We give sedation because we believe that it would spare them the trauma of critical illness, the lines, the tubes, the endotracheal tube. And so we have said we give sedation so that they sleep and so that they do not self-extubate. And so hearing this can be really jarring for many people. And I've had people repeatedly say, that is really shocking to hear. And it's really sad. But, you know, in the heat of the moment, in the ICU, it's just life or death. All we can focus on is keeping them alive for that moment and keeping that tube in place, which I think is a really fair concern and approach. But it also reflects a gap in our understanding of the severity and the risks of delirium. If all we care about is mortality, we will be panicked about delirium because delirium is an independent risk factor for mortality. It doubles the risks of dying in the hospital. For every 1 day of delirium, there is a 10% increased risk of death. Even 6 months after discharge, there is a tripled increased risk of death. Even 1 year after discharge, that risk of death is still much higher than the others. This is a life-threatening medical emergency that's occurring. And it also affects us as clinicians and our team and our healthcare system. For every episode of delirium, there's an average increased length of stay of 4.77 days and an average increased length of stay in the hospital of 6.67 days. It increases time on the ventilator. It increases the risk of workplace violence. Think back to when you've been assaulted by a patient. Were they in their right mind? Were they oriented? Did they know what was going on? Or did they have delirium? This is a huge risk for our clinicians, and it increases the risk of line and tube removals. One study showed that delirium is one of the biggest psychological burdens of nurses in the hospital, which it makes sense. Any nurse has cared for a patient with delirium knows exactly what that means. You are constantly afraid to turn your back, leave the patient. You're wrangling them. You can see the terror in their eyes. You can see the discomfort. It is just a miserable experience for everything. And ultimately for RNs, it doubles the nursing hours required for care, and it increases healthcare costs by 39%. So for many reasons, delirium is an emergency, and the risks and the consequences do not end once the patient is out of delirium and goes home. They then need to deal with the psychological trauma of sincerely believing that their kids were kidnapped, that they were raped, that the worst things were happening to them. They get to carry that with them, those psychological scars, for the rest of their lives. 1/3 of delirium survivors have PTSD 2 weeks after discharge. 1/5 still have that PTSD 1 year after discharge. And from what I'm hearing from survivors, if you go to any Facebook survivor group, they carry that with them for years longer. Please check out this QR code to hear it from them. Also, this acute brain failure can turn into a chronic brain failure. It looks like an early stage Alzheimer's that we're now calling a post-ICU dementia. Patients with delirium have 120 times greater risk of cognitive impairments after the hospital. That means that they have a hard time finding words, global and executive function, 3, 12 months, 18 months after discharge, even years after discharge. This affects their daily tasks of living, taking care of themselves. It takes away their ability to go back to work, to care for their loved ones. It completely changes the rest of their lives. Imagine how it would impact you to have severe cognitive impairments. Could you go back to work as an ICU nurse, ICU respiratory therapist, occupational therapist, intensivist, whoever's listening to this? What would that mean for you to develop delirium in the ICU, to be in a medically induced coma, and to face these repercussions the rest of your life? And then we have to look at, yes, there are some unmodifiable risk factors, but the higher the severity, the longer the duration of delirium, the worse the repercussions are. So we need to understand our role in the development of delirium. Sedation is one of the main causes of delirium and the most modifiable risk factor for delirium. We need to understand that sedation is not sleep. It disrupts the brain activity so severely that the brain cannot enter into REM cycle. And that varies by type of sedation, depth and duration and dose of sedation. So benzodiazepines are the most toxic, the most disruptive to the brain, and they therefore have the highest risk of delirium. They also have the highest risk of mortality. Benzodiazepines have independent risk factors for mortality. Propofol is also a risk factor for delirium, depending on the depth, duration, and dose of it. We also know that early deep sedation is an independent risk factor for mortality as well. So we need to understand that these can be lethal interventions. We really need to consider what medications are safer, which ones are the most dangerous. Midazolam is an independent risk factor for delirium. For every 1 milligram of midazolam, there's a 7 to 8% increased risk of delirium. So if you're giving a low dose of 5 milligrams an hour over 24 hours, that's an 840% risk increase. Lorazepam is even worse. For every 1 milligram, there's a 20% increased risk of delirium. So 2 milligrams every 6 hours is 160% increased risk. And propofol also is an increased risk of delirium, obviously depending on the patient body habitus, depth, duration, and dose of delirium. These are dangerous medications that should only be given when there's an absolute necessity and indication for it. And mechanical ventilation is not an automatic indication for sedation. And so to really prevent and treat delirium, when we really understand and we're concerned about delirium, requires some essential things. One, real sleep. Any of us become different and agitated and confused and difficult when we don't sleep. Think about your longest shift, your longest stretch without sleep. Now magnify that with critical illness and an unknown situation, being intubated, restrained, all the things. So we need to prioritize sleep for our patients, and that is not possible. Sleep is not possible when they are sedated. So we are depriving them of sleep when we sedate them. They also need to have a real family connection, which is really difficult when they're sedated. One study showed that family presence for more than 2 hours a day decreased delirium by 88%. Mobility in another study decreased delirium by 95%. Sleep, family, and mobility are really difficult when we're giving deliriogenic medications. So to prevent it, we must avoid sedation. When it happens, to treat it, we must remove those deliriogenic medications and really buckle down on these interventions. And when we see delirium, especially in setting of agitation, we should not respond with sedation, especially deep sedation. We should enable our team to utilize these interventions. So here's an example of how powerful sedation is in the development of delirium, how this culture of being terrified of unplanned extubations lead us to worsen our patients' outcomes. So Suzanne was a healthy 49-year-old that had a tooth infection, developed an abscess, which became Ludwig's angina and some sepsis. Her story is in this QR code here. If you want to hear it from her, you really should. She was intubated for airway protection due to the swelling and edema. Because of this culture that we have of automatically sedating every patient like a conveyor belt, Susanna was deeply sedated and immobile for 18 days. Had she been in an awake and walking ICU, they would have asked after intubation, does she have an indication for sedation? No, she only needed the tube for airway protection. But nonetheless, because of our culture, she was automatically sedated. She developed a traumatizing delirium and she thought the nurses were trying to kill her. Please hear it from her. What she experienced was horrific, and she's still to this day traumatized. She didn't receive a sedation vacation until there was probably a cuff leak when they thought that she was ready for extubation. So this is about 5 or 6 days after intubation. They weaned sedation down. Of course, Suzanne comes out agitated and her terror was unmasked. Due to the sedation culture, they were afraid of her having an unplanned extubation. She was agitated, so they resumed her sedation, and she heard the nurses say, quote, "She's not ready. We'll try again in a few days," unquote. And though she had no real indication for mechanical ventilation anymore, especially for sedation, she remained sedated, and the cycle continued of these failed awakening trials, and she ended up intubated for 13 days longer due to low or poor or absolute non-compliance with the ABCDEF bundle. Ultimately, finally, she was extubated 18 days after intubation. She lost 30 pounds. She was admitted to the hospital weighing 130 pounds. So she was extremely deconditioned, malnourished. It was really difficult to relearn how to sit, stand, walk, swallow. And those things eventually came back with a lot of work and effort, but she remains severely traumatized from what she'd experienced under delirium. And when we see it from their perspective, it makes sense why they come out agitated. It's not just the endotracheal tube. It's not just the ventilator. It's because they deeply believe that these horrific scenarios are happening around them and to them. And we use the word agitation sometimes in our ICU for anything that's awake and confused or restless. In the literature, agitation is a RASS of greater than 2. So this is when it becomes dangerous behavior. They're pulling at lines or tubes or trying to attack the staff. That is agitation. And when that happens, we do have to intervene. That sometimes sedation is needed during agitation, but to be used to get closer to a RASS of 0 or 1 to avoid those dangerous behaviors, and then to double down on treating the cause of the agitation. Those causes can be pain, anxiety, withdrawal, fear, lack of communication. But when we deeply sedate our patients, we take away their ability to communicate. We don't know what's going on, and we usually perpetuate the very cause of that agitation. And when we do that, we worsen outcomes and we make them at higher risk of unplanned extubations and make it a more dangerous scenario. Here's an example. This is Megan Wakely. She was admitted to the Awake and Walking ICU after a difficult course. She had baseline PTSD, benzodiazepine and alcohol dependence, and marijuana use. And she was admitted to an outside facility towards the end of alcohol withdrawal in septic shock. And she was intubated and sedated at this outside facility and remained that way for 8 days. Her septic shock was worsening. Her pneumonia, which was turning into some ARDS, was worsening, and the team there was preparing the family to transition to comfort care. The family decided to have her sent to the Awake and Walking ICU, and upon arrival, she was at about a PEEP of 14 and 80% on our ventilator settings on 1 or 2 vasopressors. So she was obviously very sick, and we were very worried about her lungs, her the vasopressor use, but we looked at a bigger picture as well. We saw her at high risk of post-ICU PTSD, considering her baseline PTSD. We worried about what she'd be experiencing under sedation. After having some trauma in her life, she had a lot of risk factors for delirium, such as septic shock, previous alcohol withdrawal, alcohol dependence, benzodiazepine use and administration during deep sedation, immobility, mechanical ventilation, ICU admission. So we were really worried about her delirium. And so we turned down her sedation, and she came out just as poorly as you would expect. She was sincerely agitated, a RASS of 3 or 4. She actually bit through her endotracheal tube, which I've never seen before and probably not since. And that obviously required an immediate tube exchange. We resedated her, did the tube exchange, and most teams would have deemed that a failed sedationification and a do not attempt until her ventilator settings were lower, right, until it was safer. But the Awake and Walking ICU really understands delirium. We also were worried about her risks for ICU-acquired weakness. We didn't see her as safe when she was sedated. Yes, she bit through her endotracheal tube, but that's not safe. Yes, she was a RASS of 3 or 4. Yes, she had high risks of unplanned extubations and a dangerous one. We also understood that there were many other risk factors for intervening with prolonged deep sedation, and we did not want that for her. We wanted her to stay alive, not just in that moment, but set her up to survive and thrive long after the ICU. We know that for patients with ICU-acquired weakness, their 2-year mortality rate with ICU-acquired weakness and diaphragm dysfunction is 36%. But ICU survivors that do not have ICU-acquired weakness or diaphragm dysfunction, 79% are alive 2 years after discharge. That's a huge difference between 79 and 30%. We wanted the 79% risk to be alive 2 years after discharge for Megan, and that was going to depend on what we did with her in that moment. We knew that obviously she was not going to be mobilizing under deep sedation, but we also recognized that sedation was going to be a huge risk factor because of the myotoxic effects. Propofol, for example, and benzodiazepines inhibit the GABA receptors. They disrupt the sodium channels of the muscle, which decreases muscle excitability. It's a neuromuscular disruption. Propofol also increases insulin resistance in skeletal and cardiac muscle, which increases muscular atrophy. It's a mitochondrial toxin, which makes it myotoxic to the muscles. One study looked at mice and gave 2 groups propofol, one with mechanical ventilation, one without. They both had the same level of diaphragm dysfunction, which makes us suspect that propofol is an independent risk factor for diaphragm dysfunction. So we knew that for every day, every drop, every hour that she was under sedation, her risks of dying would increase. We did not see her safe under sedation. We asked this important question that Dr. Wes Ely, the creator of the ABCDEF bundle, the creator of the CAM screening tool, shares in this story.
And they bring in this woman. Her name is Yuhan Kim, and she's 27. She's in a wheelchair, and she was in the ICU 2 years ago. Came in perfectly healthy, but she had idiopathic pulmonary hemosiderosis, so she bled in her lungs, which is to say that she had one organ disease. Everything else in her body was totally fine. She had no disease anywhere other than her lung. Okay, so this is as pristine of an experiment as you can essentially do in the human race. No other organ damage. And they were, and I said to them, she was in a wheelchair 2 years later. I said, why is she in a wheelchair? And I lifted up her leg, and it was just a femur with no muscle. And I said, what happened? She goes, I was in the bed for so long in ICU, I lost all my muscle mass, and it's taken me 2 years, and I still haven't built it up enough where I can walk anymore. And I said to the doctors, why did you keep her sedated and in the bed for so long? And they said, we were afraid she would self-extubate. And another doctor from across the room said, well, what if she never walks again? Wow.
That was a huge concern on our mind. Not just how do we keep this tube in her, but she really had already lost the tube. But we looked at a bigger picture. We saw her not just at this crossroads, but we saw her down the wrong track. We saw her already having been sedated, immobilized, delirious, weak. We saw her going down the straight pathway to death, whether it was under our watch in an ICU, in an LTAC, or in another ICU that she'd be readmitted to, or long after the ICU. What we wanted for her was to get her back onto course, to get her awake, mobile, communicative, autonomous, out of delirium, to really hit that goal and that vision of the ABCDEF bundle. But it took some effort. But we had to look at the big picture. We had to look at all the things on the table, all the risks at hand, not just unplanned extubations. We also knew from experience that if we could get her oriented, get her out of delirium, she'd be at less risk of an unplanned extubation. So to cover for her benzodiazepine use, we put Klonopin down her feeding tube, so withdrawal was no longer a possible cause of agitation. We kept her fentanyl drip going so that pain was covered. And then we bridged her to propofol and dexmedetomidine for the goal of getting her just on dexmedetomidine. Once we had her on Precedex, she was at a RASS of like maybe +1, 0, and we got her walking. This is one of her earlier walks. It was not pretty. She was delirious. She was weak. We had extra people here. We have a respiratory therapy student. We have family. It did take some extra effort initially because she was unreliable, impulsive, weak, right? But she was able to walk. She walked 200 feet around the unit. And then afterwards, she was exhausted. She got back into bed and she passed out and slept. And then we asked that question again. Okay, now, does she have an indication for sedation? No, she was sleeping, but really sleeping. So we took the dexmedetomidine off and she didn't need it anymore. And she continued to sleep. She'd wake up anxious, no longer agitated, but anxious. We'd walk her again. She'd sleep. She'd come out anxious. We'd walk her. She'd sleep. And she started to emerge from delirium. She told me in her podcast episode that she woke up mobilizing. That's when she first realized that she was in the hospital, that she was intubated, that her family was there. She connected with her family and we gave her a pen and paper. And the first question she wrote was, where's my daughter? For any of you parents out there, if you thought your kids were kidnapped, would you not be panicked, agitated, terrorized? Would you not want an answer to your questions? So when we give people a pen and paper, that's usually a much more potent tool to treat the agitation than sedation. And as we continue this approach, less than 48 hours later, after that first terrible awakening trial, she was free of delirium. Her lungs got worse, her cavitary pneumonia worsened. Here's her on a PEEP of 18 and 100% with a chest tube, but she's restraint-free. She's delirium-free. She is strong. She's walking. She's mobile. She's communicative. She could tell us what she needed for her fentanyl drip, for her Klonopin dose. We knew what she was experiencing, what she needed, and after 3+ weeks of mechanical ventilation, she walked out the doors. That is the ABCDEF bundle. That is keeping her safe from unplanned extubations. She went home to being a wife, or to being a mother and caring for her daughter. And all of this depends on how well we comply with the ABCDEF bundle. One study from 2019 looked at the ADEF bundle amongst 15,000 patients in 68 different facilities. Obviously, there's going to be a huge fluctuation in practices amongst that many patients. But we saw, even on this spectrum, on average, and when consider too, that only 12% of those 15,000 patients were on their feet bearing weight, right? So this is, I would say, a much lower compliance with the ADEF bundle, but nonetheless, on average, we saw a decrease in mortality after 7 days by 68%. Coma and delirium decreased by 25 to 50%. Physical restraint use decreased by over 60%. There was less mechanical ventilation use and time on the ventilator. ICU readmission decreased by 46%. Patients were 36% more likely to discharge home. And this was dose dependent. So then in that study, the question is, in regards to unplanned extubations, did they have a lower rate of unplanned extubations in the ADEF bundle group? No, they didn't. They still had the same amount of unplanned extubations. But look at how much better their outcomes were. Unfortunately, they didn't measure reintubations, but we can assume that patients were much safer. And again, this is dose dependent. The less sedation given, the more mobility applied, the more patients survived, went home, and did not come back. And that is why we intubate patients. That is the objective of it all. So when we look at the bigger picture, sedation does not keep our patients safe. It does not achieve the ultimate goal for most of our patients. One study looked at 74 unplanned extubations in 69 patients, which is about 2% of all patients on mechanical ventilation. And they found the main risk factors were midazolam, being male, the subunit of the ICU, the length of stay, which is a risk factor for delirium. And these first two categories of the Ramsey sedation scale, when patients were anxious or agitated, restless, or even just awake. And then if we're talking about reintubations, we need to understand what usually leads to reintubations. Many things can cause a reintubation, but generally we see it's if a patient after an unplanned extubation develops hypoxemia, if they have the inability to protect their airway, inadequate ventilation, altered mental status, poor secretion clearance, ICU-acquired weakness and diaphragm dysfunction, and even electrolyte imbalances, those things can lead to patients getting in trouble and needing to be reintubated. In correlation to sedation mobility practices, this is very revealing of how we can keep our patients safe, right? When we sedate our patients, they develop delirium, they have an altered mental status. Either they have hypoactive delirium or they are still over-sedated, still under the effects of sedation, still have sedation in their system that is not yet metabolized. So when an accidental intubation happens, and patients are essentially still extubated or sedated even when you've turned sedation off, they need to be reintubated. And then if patients have been immobilized, been sedated for prolonged periods of time under biotoxic medications and not mobilizing, they're much weaker. They have poor diaphragm function because they have not engaged their diaphragm to sit, stand, walk, swallow. And so the diaphragm is just atrophied away. They can't take adequate lung volumes. They can't ventilate appropriately. They can't do the work of breathing for themselves. They can't protect their airway. They can't cough adequately and strongly, so they can't clear the secretions. All of those things especially lead up to reintubation. And here's an example of how sedation sets patients up for reintubation. This is a 70-year-old male with obstructive sleep apnea, bipolar disorder. He had a C5, C6 disc herniation. And on May 14th, he had surgical repair of the disc herniation. On May 15th, he was discharged home. May 16th, he came back to the ER with insufferable back pain, and he received morphine. Now, whether it was an intolerance, overdose, poor response, he had a respiratory arrest and was intubated and had a code blue, was intubated and automatically sedated. His MRI didn't show any anoxic or hypoxic brain injury. It's unclear if they did any kind of awakening trial, but because he was intubated, he was sedated, which turned into him being sedated because he intubated and intubated because he's sedated. So finally on May 18th, someone came around and said, why is he even intubated still? Let's take sedation off, get him extubated. And they extubated him to high flow. Maybe he needed some more diuresis, but he was combative and kicking the staff. So they reintubated him, sedated him, which we should be suspecting delirium, right? On May 20th, same thing. Someone came along and said he doesn't need to be intubated. His lungs are fine. He's fine. They extubated him. He was agitated, combative, and started suffering some respiratory distress. So he's reintubated. He still stayed on minimal ventilator settings during these reintubations. But on May 25th, he developed a new ventilator-associated pneumonia, which sedation and immobility are top risk factors for VAPS. So he remained sedated, remained intubated. On the 7th, he was probably having some awakening trials. He coughed, his tube dislodged, but he was on a PEEP of 5 and 40%. He should have been fine to be extubated. He was delirious, and they let him be extubated, but he kept telling his wife, quote, "I can't breathe." And he was having her push on his upper abdomen, which sounds really peculiar, but when I thought about it, I've never had diaphragm dysfunction, but I have had people lay on my upper abdomen and I get panicked. I get agitated because my diaphragm can't drop and I can't take a proper breath. And so if his diaphragm was really that weak or even paralyzed, he really couldn't breathe. And so his wife pushing on his abdomen, maybe his subconscious, trying to get more support for his diaphragm to help him breathe. Well, he developed hypercapnia, was reintubated, and of course, because he's intubated, boom, he's sedated without an indication for sedation. On the 15th of January, he finally gets a tracheostomy, PEG tube placement, sedation's off, he's sent to the step-down unit, PEG tube becomes dislodged, he develops an ileus, PEG tube becomes infected, he's readmitted to the ICU, he's then diagnosed with a DVT and PE, likely from the immobility that he was suffering during this almost entire month. He's anticoagulated and tuned up and then sent to LTAC on June 17th. He continues to vomit from the PEG tube. He develops another MRSA pneumonia. And it's not until August 11th that he finally is strong enough to discharge home. He then had a gastric bleed from the anticoagulants, was readmitted to the hospital. He continued to struggle, needing home care at home, or home health support at home because of his mobility issues. He had cognitive, psychological impairments. He had the classic post-ICU syndrome. All of this likely would have been avoided if they had asked after intubation, does he have an indication for sedation? He could have been promptly extubated, avoided delirium, avoided a lot of these repercussions. That's the power of sedation and immobility, and this culture of not being able to treat delirium because we don't understand how to treat it. So when we look at reintubations, 100% of accidental intubations, those that happen during bed baths, transport, going from the bed to the stretcher, what have you, 100% of those have to be reintubated. And I imagine that patients being actively sedated during that time is a top contributing factor. But only 37% of self-extubations require reintubation, which reaffirms my theory that for most patients, if they're strong enough to pull out their tube, if they're awake enough to pull out their tube, they're likely strong enough to be off of mechanical ventilation. And so we also see that those that are reintubated have an average of 11 days longer mechanical ventilation, 13 days more in the ICU, 16 days longer in the hospital, and a 14% increased risk of nosocomial pneumonia if they have to be reintubated. So reintubations come with risks, but the risks of reintubation are far less. The less sedation we use, the more we mobilize patients. And we know that self-extubation is associated with a lower rate of mortality. So which is more lethal? Which is more dangerous? If we really just want our patients to survive, is sedating them to keep the tube in the best strategy for improved mortality? Or is the ABCDEF bundle the best strategy for improved mortality and keeping our patients safe from the event of self-extubations, but also from the risks following self-extubations? Here's an example of that. Kenneth Hurwitz was one of our first COVID patients in the Wake and Walking COVID unit. He was 69 years old. He spent the first 6 days on mechanical ventilation, awake and walking around in his room, texting his wife, cam negative, and then he got worse and he needed to be proned. He proned himself for the first 2 days, could still ride on the board while proned, and then after he got worse, could not oxygenate with movement. He then required deep sedation and paralysis for 6 days. For in total, he was proned for 8 days. Once he could be supine and oxygenate with movement, then it was time for an awakening trial. When we could see that he could oxygenate with movement, there was no longer an indication for sedation. It was no longer worth the risks of sedation. So he took sedation off, and he was delirious, and he was weak. And so they promptly got him back on his feet to treat the delirium, to rehabilitate him from the weakness, the ground that he had lost during that sedation. And he was delirious, right? So he would sit up in the chair during the day, and 4 days after being supine, after all this rehabilitation, the respiratory therapist walked into his room, again, no family, total isolation, and he's holding the endotracheal tube in his hand. He was probably, I would imagine, like a PEEP of 10 and 50 or 60%. And he was probably desatting. But there he was holding the endotracheal tube in his hand, and the respiratory therapist was panicked and said, "Ken, what are you doing?" And he said, "I didn't need it anymore." And he wasn't wrong. He was able to be on high flow. And let's look at that scenario. What led him to self-extubate? Obviously, lack of family presence, isolation, sedation, all of that led up to him having delirium, which increased his risks of pulling out his tube because he couldn't understand it. We could also say that he was insufficiently restrained in the chair, right? And he was, according to the studies, inadequately sedated. But what helped him succeed and not be reintubated? Being awake, not being sedated, being mobilized before and after sedation, being strong enough to take deep breaths, cough, protect his airway. He could then tolerate high flow nasal cannula. We continued to mobilize him, and we didn't just sedate and mask his delirium. That is what helped him succeed, the ABCDEF bundle. And so 10 days after being supine, after being extubated, he was discharged straight home from the hospital. 6 weeks after discharge, he was golfing for his 70th birthday. 2 weeks later, so 2 months after discharge, he emailed me to tell me that he had walked 8 miles golfing. That's 2 months after discharging from the ICU from severe COVID-19 and ARDS. At 70 years old, he walked 8 miles. This is his story. Scan this QR code, listen to him tell his story, and how grateful he is for the ABCDEF bundle. We also have to consider, when we're keeping patients safe from unplanned extubations, we have to have proper tube securement. We need devices that support patients and keep the tube in place during mobility, not just with the expectation of patients being completely immobilized. We need tube securement devices that understand that patients are going to be turning their heads, walking, really mobilizing, that don't have kinking, sliding, that they're comfortable for patients. And our staff needs to be trained on how to use those devices. We also need better restraint technology. I think we're all used to the soft wrists, the mittens, the elbow restraints, but we know that those increase trauma, increase agitation, they restrict mobility. There's a close correlation between restraint use and delirium, and this all plays in. When patients can't mobilize, it exacerbates the terrible scenarios that they're living in their minds when they are delirious. But if patients are agitated, we can't just let them have free hands and pull out their lines and tubes. So I'm excited to be seeing newer technologies developed. I have no bias, no investments into exercise, but please check out this company. They develop a restraint replacement called RESTRAINTS. And this is a titratable level of restraint. Patients can be mobile, move their arms, but they cannot get to their tubes. They cannot pull them out. And then there's also another strap beyond what is shown in this picture, so that when they are having dangerous behaviors, RAS of 3 or 4, you can restrain their arms to the bed. But this is the kind of technology we need so that nurses and the whole team feels more comfortable avoiding sedation and being able to keep patients awake and mobile without the fear of unplanned extubations. We also need better communication technology. When we have patients that cannot communicate, it increases agitation. It leads to higher risks of sedation, higher risks of unplanned extubations. We need to make communication and a humanized approach in the ICU a greater priority. And then patients can help participate in keeping their endotracheal tubes safe. So all of these approaches are going to help keep our patients safe. I would also mention that we need a culture change. We need to, if we want to avoid sedation, we need to have a culture in which nurses feel supported and protected, that they are not the only ones bearing the liability of unplanned extubations. And here's what I mean. One podcast listener reached out to me telling about a patient that she had that was on higher ventilator settings, newly intubated. He had a psych history, but he was not delirious. And she understands all the risks that come with sedation. And he didn't really have an indication for sedation. But this was during COVID. There's no family at the bedside. So she was asking for a sitter from her management. And she was told, nope, just sedate him. He just needs to be sedated, just sedate him. And she knew what evidence-based practices meant for this patient. The best practices would be avoiding that harm for him. So he wrote on the board, I promise I will not pull my tube. He was restrained. She went to go check another patient. He got to his tube, self-extubated. He did have to be re-intubated. And that very same attending rushed into the nurse manager's office when they were about to rip her a good one, to punish her, to chastise her for not having the patient sedated. And he said, this nurse is practicing better evidence-based medicine than the rest of the team. And if she gets any heat for this unplanned extubation, you'll have me to answer to. That is leadership. That is collaboration. That is evidence-based medicine, to look at the big picture. Instead of just how to keep that tube in place for that one day, we had to look at the big picture. And another example is another physician who had been really leading his team to become a minimal to no sedation unit. He had a patient that was kind of borderline, maybe ready to be extubated, didn't meet all the parameters for extubation. And so he thought, we'll just leave them another day. Well, the patient got to their tube, self-extubated, and didn't even need high flow, was fine on nasal cannula. But the nurse, he found the nurse at the nurse's station totally demoralized, feeling sick, like they'd done the wrong thing, that they were the worst nurse ever. You know, nurses are so hard on themselves and hard on each other. They considered it a failure because the patient self-extubated. He sat the nurse down and said, look at the big picture. Had he been sedated, maybe he wouldn't have self-extubated today, but he probably would have later, and he would not have been able to succeed, and he would have been re-intubated. He would have had a tracheostomy. He would have gone to the LTAC, right? Look at what could have happened. But today we have a success. Yes, he self-extubated, but he was awake. He was strong because of the care that you provided. This is a success. That is the culture, that is education, that is the environment that we need to create in our ICUs to really keep our patients safe. Again, not just from the occurrences and the rates of unplanned extubations, but from the repercussions. And as we do that, we can find greater fulfillment and success in our ICUs. And I'm happy to share this with anyone that needs it. To answer any questions, please contact me. My website is DaytonICUconsulting.com, or you can scan this QR code. Let's chat. Let's talk about how your team can also become an awake and walking ICU to decrease patient harm, improve patient outcomes, healthcare costs, staff morale, staff retention, all the things. Let's turn this around. Let's do the right thing for our patients. Thank you so much for being interested in improving patient care.